Thank you, sir. Good morning. Great pleasure to be here. I'm going to, I hope, complement the previous talk and major on MRC and C. diff, but look at some of our local data, which by some detailed analysis, I think fairly robustly attributes some cause and effect to the declines in these illnesses. There's my disclosures, and I should say that this particular talk is sponsored by Basilea. Just to highlight where Aberdeen is, with apologies for this pre-independence referendum map. The reason really for highlighting where Aberdeen is, it's far away, obviously. I've always come down to do missionary work in East London. It's most enjoyable. But the other thing is, of course, it's the home of the Staphylococcus. Discovered here in post-operative wound infections in 1880 by one of my heroes, Professor Sir Alexander Oxton, Professor of Surgery. You don't often get a microbiologist sitting with a surgeon, one of his heroes, but there you go. And there you can see him also. He was a great friend of Joseph Lister's and one of the first to take up the carbolic spray. And Sir Alexander wouldn't be surprised that staph is still number one pathogen for many of us, the Darth Vader of bacteria. And he wouldn't have been surprised with the campaign for the general election in 2005, which maybe arguably is when it all really kicked off, when it was MRSA was one of the top 10 issues in that election. And the good news was that brought plenty of money in for hospitals to control it. And the UK, which had stood out rather oddly as being an honorary member of Club Med in its MRSA rates, then was able over the next few years to bring rates down pretty satisfactorily, as you've already heard. This slide shows it in bar form, but it also shows what's you might have noticed from a previous speaker, but isn't often commented on, is that MRSA, and indeed most antibiotic-resistant organisms and infections are not replacing susceptible infections. So MRSA didn't replace MSSA as a cause of active disease. It's an additional burden of infection. And same is obviously true for C. diff and probably for gram-negatives, certainly for fungal infections. We've seen a doubling in E. coli and Klebsiella bacteremias in the last decade, and that's probably due to multi-drug resistant clones like ST131 E. coli being an additional burden of infection. The sensitive E. coli strains haven't gone away. And ultimately, this is all down to antibiotic use. If there were no antibiotics, we would not have these multi-drug resistant organisms. So not only are antibiotics causing resistance, they're causing, paradoxically, an increase in the number of infections. And arguably, although it's nice to see a decrease in case fatality rate for MRSA and C. diff, arguably, a lot of these infections are more serious than those due to the susceptible variants of these organisms. So there's a lot of issues about antibiotic overuse, not just antibiotic resistance itself. And perhaps we were one of the first to flag this up in the early days of the MRSA outbreak, and this is data from our own hospital. And you can see the early peaks, the winter peaks in prescribing of cephalosporins, quinolones, and macrolides due to rather over-enthusiastic implementation of British Thoracic Society guidelines for treatment of community pneumonia. These peaks in antibiotic prescribing were driving peaks in MRSA. You can't see from the graph, but actually the peaks in prescribing precede the peaks in MRSA by a few weeks. And the model predicted, believe it or not, that in the early phases of the outbreak, if we stopped prescribing these three groups of antibiotics, the MRSA outbreak would have stopped in its tracks within 6 months. Nothing to do with infection control, just stop using these antibiotics, which all the MRSA strains, talking about the E15, E16, were resistant to these antibiotics. heavy prescribing of these antibiotics, most of it unnecessary prescribing, was driving the MRSA outbreak. Of course, if at the time I'd said, oh, we can't use these antibiotics, stop prescribing them, I would have been carted off the local mental hospitals in the city. These antibiotics were essential for good health in the hospital. But we got a chance to actually to look at some of this, not through wanting to stop use of these antibiotics for MRSA, but because, of course, of C. diff. And in Scotland, like in England, we've really come down heavily on prescribing of cephalosporins and quinolones, clindamycin. Also, colmoxiclav and macrolides have been targeted in Scotland as well, because the MRSA strains and C. diff are resistant to many of these antibiotics. And actually, we can see from arena modelling of the various interventions, first of all, the National Hand Hygiene Campaign in 2007, then introduction of universal emission screening in August 2008, and then what we called in Scotland the 4 C's antibiotic stewardship policy, brought in for control C. diff, started in May 2009. We can see fairly dramatic reductions in MRSA, just as you saw and you've seen in England. But using arena modelling, we're fairly confident that the antibiotic stewardship was the dominant dominant cause of the drop in MRSA, although there were significant contributions from hand hygiene and the universal admission screening. And it's also interesting to speculate, one of the reasons for the drop in case fatality in MRSA is screening allowing early awareness of MRSA carriage and thus more rapid, appropriate treatment. Just turning to C. diff now, and it's well known that at least the outbreak strains like 01 and 027 are somewhat unusually for Clostridium difficile. They're quinolone resistant, and quinolones I think definitely have the worst name in terms of C. diff outbreaks. But cephalosporins also, as you can see here, have to bear some responsibility. If we look at the bottom of the graphs here, you see the decline in C. diff in our hospital, and the different colours show all the different strains, and it's the 2 yellow strains, which are the 2 outbreak strains, which really have seen the most reduction, and thus bore most of or given most of the effect of control of C. diff. And actually, using not only arena modelling, but introducing Mars modelling, we can look at non-linear effects of the relationship between the control of C. diff, or MRSA for that matter, which we've already published on, and in this case C. diff here. Apologies for the complexity of this slide, which isn't published yet, but for 3 hospitals and for the community, we can look at the associations between various antibiotic prescribings and Clostridium difficile. And what's dominant, whether in all the hospitals and in the community, fluoroquinolones come out as major drivers of the C. diff outbreak. But apart from that, it's not consistent. One hospital, it's colmoxiclav is the other driver. One hospital, it's the 3rd generation cephalosporins like ceftriaxone. One hospital, it's the macrolides. And in the community, I think it's clindamycin as well as quinolone. But the strongest associations in terms of p-values are the quinolones, and the weakest association actually the cephalosporins. So something interesting there maybe. This brings us to some difficulties in understanding where we're going with antibiotic stewardship, because antibiotic policies, antibiotic guidelines, antibiotic stewardship tends to drive uniformity of prescribing. But if you're going to have a relationship between antibiotic thresholds and the prevalence of a disease like MRSA or an resistant organism like MRSA or C. diff, then if you can reduce the absolute amounts of prescribing of these key antibiotics below the threshold, then they'll have much less selection power on resistance. But then you, of course, will need to bring in other antibiotics have more diversity. And that's the sort of thing that's actually difficult for antibiotic policies and guidelines to cope with. So, interestingly, there's another cephalosporin on the market. Do we need it on a cephalosporin? Look at the relationship with Clostridium difficile, notwithstanding it's not as bad as with quinolones. Well, the interesting thing about this cephalosporin made by Basilea is it's an anti-MRSA cephalosporin, which sounds a bit paradoxical, but there you are. It's got improved binding to penicillin binding protein 2, which is the target that's changed and makes resistant to most beta-lactams. And it's licensed for community and hospital-acquired pneumonia. It has, as well as good, cover against all staphylococci, including coagulase-negative staphylococci, which may be interesting for future unspecified uses. It's also got good gram-negative activity, but it's not active against ESBL, so it's a pretty typical third-generation cephalosporin in that sense. And there are breakpoints for ceftibacter against the major organisms. You can see it's also quite active against Pseudomonas. Sorry, there's the breakpoints there. Now, the key issue is, I think, if this antibiotic is going to be successful, and I think it certainly has a role as an anti-MRSA agent, is what is it going to do to C. difficile? How concerned should we be? And the data so far isn't that bad, and we can speculate that's because it's got increased activity against gram-positives, not only MRSA, but also against enterococci and Clostridium difficile itself. Inherently, all cephalospores up till now have been inactive against C. diff. C. diff's been resistant to them. That's not the case with ceftobiprole because of its different penicillin binding protein. Also, it doesn't critically, I think, get into the gut. That must be important in terms of upsetting bowel flora. And there's various levels of data I just wanted to go through briefly, just to back up the suggestion that maybe ceftobiprole is worth considering in the context of having more diversity of antibiotic prescribing rather than flogging the same old antibiotics over and over again and finding new thresholds for drug-resistant organisms. So as I said, it is active against Clostridia, unusual for cephalosporin. But it doesn't disrupt the majority of the bowel flora, such as the Bacteroides species. And healthy volunteers given ceftobiprole show no disturbance of the bowel flora, which you can't say the same for other cephalospores, particularly ceftriaxone, which is put out in large active amounts through the bile into the gut, which may be a critical issue. And there, in mice, ceftobiprole does not increase the propensity to C. diff any more than Sealy does, which again is not the same with the other cephalosporins. And in the clinical studies for registration of ceftobiprole of over 1,000 patients, there has been only one case of Clostridium difficile. Early days yet, of course, so we have to keep an open mind. So in conclusion, there are many paradoxes to antibiotic prescribing. I've mentioned some of them today. I'm not sure we have clear answers, but obviously antibiotics, unlike most other groups of drugs, have many complicated effects at a societal level, and that society might be the ward in the hospital, it might be the whole hospital, or it might be the community at large, and individual prescribing does affect these things. And with homage to Bob Dylan, just a little poem or song which will be released. No, I won't be singing, but I may read some of it out. Mama, take old cephalospores off of me, I can't use them anymore. There's ESB on every P colonizing the hospital corridor. Not in the pharmacy store, the microbiology store, the infectious disease specialist store, and the prevention control teams. Mama, put the quinolones in the ground. They're not useful anymore. SAPG, Scottish prescribing groups coming there, lock the carbapenems in the store. Take the clindamycin off of me and the comoxiclav too. There's C. diff as far as I can see, and MRSA is nothing new. Put the macrolides in the ground. It's a viral illness anyway. Don't give it in your judgment time. Just send your patient on their way. take the ciprofloxacin off and be, it's almost always overkill. There's not much from GSK or Eli Lilly. If we don't say them, no one will, etc., etc. And finally, I've got, thank you. Well, you can transfer your pulse to buying my latest book. It's all in there. I've got 2 daughters getting married this year, so I'm used to it. Thank you very much.